All right, guys. So, welcome to the SB single best responses session of the first paper in surgery, Gyn OBS paper. Okay. All right. So, we're talking about this paper. Hope you got the proper paper with you. This one. All right. Okay. So let's take the 26th question. A 41-year-old mother presented on her 12-week POA following three uncomplicated vaginal deliveries. The last child was 11 years old and BMI was 22 kilograms per meter square. The pregnancy was uncomplicated up to now and she is currently on folic acid 1 milligram and calcium supplements. But it's the most appropriate next step of management. So there are various things given. So calcium supplements, iron and all. So this is guys, now when you see this sort of an history, what they're usually referring to is not usually read it well, but here this is something like a pattern recognition. When you see some things like what are the off things you see in this patient, 41-year-old, bit older, no, bit older, and then last child was 11 years old. So there are some important things you need to identify. So so those are the main two things that is mainly indications for uh okay, is this indications for aspirin. Okay. All right. Okay. 1 second. So these are the risk factors for aspirin. High risk factors and moderate risk factors. I think we spoke about it before as well. So have a good idea. High risk factors, even one is enough for aspirin. Moderate risk factors, you need to have two. So if there's one high risk factor and two moderate risk factors, we will give aspirin 75 to 150 milligrams per day from 12 weeks on till POA of uh, till birth. Okay. So in this case, so the patient was 40 years of age and pregnancy interval was more than 10 years. So therefore, there are two minor moderate ones. Therefore, we can negate for aspirin. Okay. So it's going to be aspirin. Folic acid, is it needed now? No. The another very important thing, guys. Now we talked about folic acid being there are some uh, cases where you need higher doses of folic acid, which is 5 milligrams. Now, this 5 milligrams, when should you take it? You should take it in the preconceptional period and in the first 12 weeks. That's all. After 12 weeks, guys, your brain development has already been formed. Okay? Neurotube defects. If there was going to be defects, now it has already formed. And if there were no defects by 12 weeks, from there onwards, there won't be any neurotube defects as well. There's nothing to come after 12 weeks, because by the 12 weeks, your neurotubes are developed fully. So therefore, uh, well, my point is, even if a patient is indicated of 5 milligrams of high doses folic acid, after 12 weeks, that can be converted to 1 milligram of folic acid. Okay. So the folic acid of 5 milligrams does not have to be taken till the end of pregnancy. So it's a very important thing. Okay. Preconceptional period and the first trimester is when you use this 5 milligrams. Second trimester and third trimester, you can go for 1 milligram. Okay, that's for folic acid. Okay. Now, in this case, even if there were indications for folic acid, I mean, there are no indications. No, now you know what the indications of folic acid are. No, that we started at the top. No? These sort, nothing of this sort are there in the question. So obviously it's out. But even if there were the patient was anti-epileptic with on anti-epileptic drugs, so having either of these conditions, after 12 week and onwards, there's no point of giving 5 milligrams. You can switch to 0.4 milligrams or slash the 1 milligram. Okay. Um, so that's a very important thing, a practical thing. Okay. So this is going to be now. And therapeutic dose of iron, there's no indication. No, there's no, I mean, like, uh, no pictures of anemia. This calcium supplement, there's no reason. Initiate micronized progesterone. So I think I spoke about the indications for progesterone and progesterone. Okay, so these are the indications for uh, so these are the indications for progesterone. A history of preterm birth, or a history of T2 miscarriage or stillbirth. Okay, or cervical length of 25 millimeters or less in the transvaginal scan. Okay, history of preterm or history of T2 miscarriage or stillbirth. So always, guys, when you have problems in these gynecological things, obstetrics, just go by the criteria, indications. Because indications, definitions, they will guide you through all the gray areas. Okay? No? Don't be hesitant. So therefore, that's why it's important to remember these small things which I'm telling you to remember. Okay? Okay. That is also wrong. All right. So let's go to the next one. 20 Radial time presented with vaginal bleeding for 1 hour. Estimated blood loss 1 liter. Pulse rate is 90. Blood pressure is 100 by 60. On abdominal examination, it was soft and fundus is above the level of umbilicus. Episiotomy had been sutured. Oxytocin infusion commenced 30 minutes ago. What is the most appropriate management? Now, what are we talking about here? We are talking about a PPH, a postpartum hemorrhage. Okay. Now, we need to know how to manage a patient with postpartum hemorrhage. Okay. So now when we speak about a patient with postpartum hemorrhage, okay, when we speak about a patient with postpartum hemorrhage, there are mainly 4 T's. No, we have the 4 T's, which is tone, tissue. So tone means uterine atonic, uterine atonic, meaning the uterus is not contracting well. Tissue is if there are retained products of conception, or things like placental pieces in the uterus and no. Retained products of conception. Retained products of conception. Tone, tissue, then trauma. Any genital or cervical tract injuries. Or if there's thrombin. Thrombin means if there are any coagulopathies. Coagulopathies, because in labor and all, there can be coagulopathies that can cover. Things like DIC is a possibility. And also if the patient is having an underlying coagulative problem and it has not been detected in the pregnancy, that can also be a reason. Okay. Now, there has to be a methodical way in which you have to select on what is the cause for this postpartum hemorrhage. Okay. So now, what is the initial step? Initial step before we look for the cause is to initially stabilize this patient. So you need to get the IV to wide bore cannula, and then I need to send for blood and DT, and then you need to get transfuse blood. Make sure the patient is stabilized. Okay, make sure the patient is stabilized. Okay, all right. So then the next step you do. Okay, the next step you do now when we have stabilized the patient, but still the patient is bleeding. Now you need to see why is bleeding. You have to exclude these 4, and when you exclude these 4, you have to do it in a methodical way. Okay, the first thing is you look for the retained products of placenta. Okay, you see for the retained% of products of placenta, where I put the patient on lithotripsy position, put 2 sim speculum, and then look at the by putting the green armitage. So sim speculum and using the green armitage, you are lifting the cervical lip up, and then by that, because at this point, guys, the cervix is dilated, everything's dilated, so therefore you can easily lift up the cervix and see for the uterus to see if there are any retained products of conception in the uterus. So if there are things like that, you can manually remove them and clear the cervical canal and vagina. Okay. Now when you have done that, if there are cases, you can remove them. If there are no, that means it's not tissue. No? It's less likely to be tissue. Okay. Now remember this. Okay. This is a methodical way. This is a logical way of going through to differentiate one from the other. Okay. So then no. So then you see is the next you see is the uterus below the umbilicus. Okay. If it is no, then you know for sure that it is going to be atonic hemorrhage. Because guys, now what should happen usually is in the postpartum period, your uterus has to contract. And when the uterus contracts, if the uterus contracts properly, the uterus level has to come down. It has to come down below the level of the umbilicus. It makes sense. No? Mhm. This is the umbilicus. So if the uterus is like here during the pregnancy, when it contracts, it has to come down to a level of below the umbilicus. So, so if it has not come down, then you know it is the fact that the uterus is not contracting well. So then you have the management. So this is the main management for atonic hemorrhage. Okay, atonic hemorrhage, also called as the yeah, atonic hemorrhage. Okay, atonicity. Then the tone is there, and that's the commonest cause of postpartum hemorrhage. So you need to know your thing well. So you should do try massage. Then if oxytocin has been given, then you can give ergometry. Okay, if ergometrin has been given initially, you can give oxytocin. So you can go back and forth like this. Okay, so you have to give both. Like if the oxytocin has been started, then you look for some time, and then if it does not relieve, then you have to give ergometrin. Okay, and while doing this, you also need to do bimanual compression of the uterus. Okay, so all of these you do at like around the same time. Okay, so if it not settles, then you can give tranexamic acid. Okay, tranexamic acid doesn't have anything to do with the uterine tonicity. It sort of it's an antifibrinolytic. Antifibrinolytic. It prevents the breakdown of fibrin clots. Okay, tranexamic acid. It has nothing to do with the uterine contraction per se. Uh, now, just to recap on why is the uterine contraction important for to prevent the bleeding? Because when the uterus contracts, the blood vessels in there it gets collapsed. Okay, it gets strong, it gets collapsed. No, so therefore the blood. Uh, so it's like you have a a hose like this. You collapse. You do like that. When you do that, you stop the bleeding. So that's what the uterus is supposed to do by contracting. Okay. So doing the uterine massage, bimanual compression of the uterus, oxytocin, ergometrin. What it I do is we sort of contract the uterus. So if they are not settled, then give tranexamic acid. Tranexamic acid, as I mentioned, is primarily to prevent the bleeding. Okay, and then also you can give misoprostol or carboprost. Misoprostol or carboprost. Okay, so misoprostol is what? It's a PGE1. Okay, these are very important things. Okay, PGE1. There are three types of prostaglandins: PGE1, PGE2, and PGF2 alpha. PGE1 is misoprostol. Misoprostol is mainly used for legal termination of pregnancy for abortions. But also PGE1 is used as a second to third line drug for postpartum hemorrhage as well. So that PGE2 is what you call as dinoprostol. Dinoprostol, that is what you use for induction of labor. And PGF2 alpha, that is carboprost. PGF2 alpha, they are mainly used for postpartum hemorrhage. Okay. And if it doesn't settle, you can go for uterine balloon tamponade, which is called the Buckley catheter, where you put the Buckley in, where you put like a balloon in. Okay, so suppose this is the uterus, and you put a balloon sort of thing, and you inflate it. So thereby it exerts pressure onto the wall of the uterus, thereby to prevent the bleeding. Okay. So but now if the uterus is below the umbilicus, then what is the if the uterus is below the umbilicus, then what the next step you do is inspect for genital tract and trauma. Okay. So C for high vaginal and cervical tears, exclude paravaginal broad ligament hematomas, and if they are the case, you have to do for folic catheter and vaginal packing, and you can do a surgical evacuation. If there is like paravaginal hematoma is if there's a hematoma present in the the vaginal wall, so in the vagina basically. Okay, basically due to trauma. Now, if that's also not the case, usually it could be something like a thrombin. No, thrombin means a problem in the coagulopathy. Okay, thrombin means a problem in the coagulopathy. So in that case, guys, the main manifestations of a, if it is a coagulopathy problem, is it's not just going to be pervaginal bleeding. The patient will have bleeding from other sides as well, hematuria, PR bleeding, and other sort of problems as well. Okay, so I have sort of revised the whole postpartum hemorrhage, how to differentiate what from what aspect. Okay, so all right. So now coming back to the question, uh, see, the fundus is above the level of the umbilicus. When you say fundus is above the level of the umbilicus, guys, mainly the main thing to think of is going to be atonic hemorrhage. So therefore, if the patient has been given oxytocin, next step is give IV go metric. Okay, because there's no other reason for the fundus to be above. And also you see soft. Fundus is soft, the uterus is soft, and the fundus is above the level. If you take a normal uterus is contracted, it should be hard, no? Firm to hard in nature. All right. So these are all unnecessary because they are all not uh, needed for the management here because it's mainly a atonic hemorrhage. Okay. Okay. A 25-year primary gravida on spontaneous labor was reassessed after 4 hours duration at the labor room. Abdominal examination, head palpable 2/5, station is -1, molding is 1, cervix is full dilated, CTG is pathological. Next step in the management. Okay. Now this is the classic CTG case. Now let's see. Now this is a abnormal labor case. Okay. Now, always guys, remember, I think I've explained this process many a times. When you want to approach a abnormal labor question, the first question you should ask is, which stage you are in? Okay, which stage you are in? Are you in? Are you in the first stage, later stage of first stage of labor? Are you in the active stage of first stage of labor? Are you in the propulsive phase or the passive phase of second stage of labor? Or are you in the expulsive state or the expulsive state of, or the active state of the second stage of labor? Or are you in the, that's mainly thing. Those are the main 4 places. No? And then third stage is going to be after delivers the baby. So by that time, labor has already finished. So this is very important. So you should know them, which stage you are in. Okay. All right. So then second thing you should ask is, do I need to intervene? Do I need to intervene? For you to answer that question, there are only 2 places where you need to intervene. One thing is if there is fetal distress. The other one is if there is delayed stage of labor. I'll quickly now there are various definitions for delayed stages of labor, and I hope you know them well. Okay. If not, then it's the bread and butter of labor. So you can refer your notes, own notes, for you to and go and see what are the delayed stages of labor. So you should know the delayed stage of first stage of latent stage of labor. You should know the delayed active stage of first stage of labor. Then you should know what you mean by delayed second stage of labor, so on and so forth. So if there is either delayed stage of labor or if there's fetal distress, you need to intervene. Okay, so those are the 2 things you ask. And then from those 2 points onwards, you can then carry on your management as appropriate. Okay. So Now, in this case, okay, so in this case, CTG is pathological. Now, there are no time duration, so we can't even think of the stage we are in because they have not given any cervical dilatation or anything like that. Yeah, so sorry, cervix is fully dilated. No, so cervix is fully dilated means what? What do you mean by cervix is fully dilated is uh, now we are in the second stage of labor. Okay, from 0 centimeters to fully dilatation is what you call the first stage of labor, and actually 0 to 5 centimeters and 5 to 10 centimeters. That's the active passive stage of labor and active stage of first stage of labor. And then after fully dilated, so the cervical dilatation, now you are in the second stage of labor. So that is the second stage of labor is true. Now, now the other thing is for you to diagnose. Now then you should ask yourself. Now in this case you need to intervene. That's for sure. So because CTG is pathological, you need to intervene. But also at the same time, guys, it's good if you can go and revise on what you mean by delayed second stage of labor. So it will again, delayed second stage of labor will depend on the primary gravida or multi-gravida. For a primary gravida, it's going to be 2 hours. So delayed second stage of labor is if it is taking more than 2 hours for a primary gravida. For a multi-gravida, it is going to be 1 hour. So multi-gravida, it's going to be 1 hour. Okay, I'll just so here I have sort of taken a screenshot from uh, my note and I put it here so that it's easy for you to revise it. So for later first stage of delayed is this. Okay, delayed first stage of labor is it is more than 12 hours for primary, more than 8 hours for multi-gravida. And delayed first stage, active stage of first stage of labor, there's 2 types called primary dysfunctional labor and secondary arrest. So there are 2 definitions. Less than 2 centimeters in 4 hours, that is primary dysfunctional labor. And secondary arrest is no cervical dilatation for more than 2 hours after normal active phase. Second stage of labor for a primary, it is more than 2 hours from the start of the active second stage. Okay. Multi, it is more than 1 hour from the start of the active stage of labor. Okay, because now guys, second stage of labor you have the passive and the active stage. Okay, in the first stage you have, in the second stage also you have these two parts, passive and active. So we diagnose timing with regards to this from the start of the active second stage. Okay, but sometimes in the question papers they say fully dilated for 2 hours. So when you said fully dilated 2 hours, that is what, that is the timing of the second stage. Okay, but technically, theoretically speaking, it should be from the start of the active phase. Okay, because so cervical dilatation, full cervical dilatation is the start of the uh, passive phase. Okay, of the second stage of labor, and up to the point there, mother gets the urge to push. When the mother gets to urge the push is where you have the start of the active stage of second stage of labor. Okay. So the guideline according to proper way, from this place within 2 hours. Okay, from this place within 2 hours, the primary has to deliver and the multi has to deliver within 1 hour from this place. Okay, so that is the proper way. But in exam papers, guys, they take this whole thing as the start from the start of the second stage, the clock, they start from this place onwards, from the full circle dilatation. So don't think about that. That's also taken as this. So basically, for exam purposes, if you want to get the timings right, just remember second stage of labor. For a primary, it has to be done if it takes more than 2 hours in the second stage of labor. And for a multi, if it takes more than 1 hour of labor, it's going to be diagnosed as delayed second stage of labor. Okay, so now we have spoken about latent, what you mean by delayed first stage of labor, then delayed active stage of first stage of labor, and then delayed second stage of labor. All right. Okay, so now in this case, now yeah, I went a lot out of the question, but now in this case, now this is not needed, no? So we don't have any time durations, no? So had they said 25-hour premigravital spontaneous labor was reassessed after 4 hours duration of labor, uh, abdominal examination is helpful, and then all of this, and cervix is fully dilated. And if they say in 2 hours time, still the patient has not delivered the baby, then you know it is a delayed second stage of labor, because from the cervical dilatation to 2 hours, no? So it's okay to take it as delayed second stage of labor. Although the proper diagnosis of delayed second stage of labor should be from the point where the mother urges to push, because that is the start of the active stage of second stage of labor. Cervix fully dilatation is the start of the second stage of labor, which is started with the passive stage of second stage of labor, and now only after the mother gets the urge to push only, you get the active stage of second stage of labor. So don't get it confused. Okay. All right. So what? As I mentioned, for exam purposes, they can give it in because they won't go into depths of that. They will just say the second stage of labor was 2 hours or more. So get that. Okay. Um, so now in this case, CTG is pathological. Okay. So CTG is pathological. So we need to intervene. So then, what are the ways in you can intervene? So now in this case, guys, uh, what are the things? So can you reassess after 30 minutes? No. Delivery by vacuum, ring release forceps. Both of these are instrumental delivery. Now there are some indications and there are some contraindications for instrumental delivery. Abdominal examination, head palpable 2/5. Okay. So this is an contraindication for instrumental delivery. So what are these? So there should be some prerequisites. Okay, there are something called prerequisites for operational vaginal delivery, which you like they indicate, or like the things which should be qualified for the patient to undergo operative vaginal delivery. So this is list. Unfortunately, we'll have to know them well. And here you say head is fully engaged, less than 1/5 palpable. Head should be palpable less than 1/5. Okay. So head shouldn't be palpable more than 1/5. Head shouldn't be palpable more than 1/5 here, but abdominal. But here the abdominal examination, the head is palpable 2/5, meaning the head is still up. It does not come down alone. Okay, because now, suppose okay, so if the baby's head is going down, it has engaged deep in the pelvis, then this is the abdomen. So this is the head, this is the pelvis, and this is the abdomen, this is the pelvis area. So now, if the baby's has not descended a lot, the baby's head will be somewhere here. So abdominal, you can palpate the head well, no, 5/5. This is a fifth. But if the head has engaged deeply, then how much? No, this is the pelvis. No, this is where the pelvis starts. This is the abdomen. So if the head is very, very deeply engaged, can you palpate the head abdominally? No, you can't. So that is that. So uh, head should be at least less than 1/5 palpable abdominal. Okay. So these are the other things. Okay, so remember them, man. I have given some other information with regards to the station, head engagement, ischial spine, and the head palpable abdomen. Okay, so read them out. Okay, so I have been with these are very important things. I have uh, summarized all the things. Okay, these are very important points for you to know for your exam. Okay, so read them out, and if you have any problem in understanding them, you can let me know. And this is also very important uh, for you to get an idea of instrumental delivery. Okay, when you read these things, when you read this thing out, you can. I'm pretty sure that a lot of your confusions will be sorted because instrumental delivery is a area which is not understood very well. Okay, with the students. Okay, all right. So these two are out. These two are out. So then you have either prepare patient for type 1 emergency C-section or place a mother in left lateral position. Now, guys, when you want to treat a patient, when there's an abnormal CTG, now in this case, guys, now we are in the second stage of labor, no? Okay, that's sure, no? We are in the second stage of labor. Now, we need to intervene. Okay, we need to intervene. We need to intervene because there's fetal distress. And then if when you consider the management options for that, here you have operative vaginal delivery and emergency C-section. And there's oxytocin infusion also, but in this case, they have not given that. Okay. Pain relief is also. So mainly these are the two things where you need to take the baby out. Okay. Operative vaginal delivery and emergency C-section are mainly the two ways in which you can get the baby out. Now, yes, you need to go for emergency C-section. That would be the best one. That would be the best way to go about this. But also, guys, remember when you what you mean by CTG, a pathological CTG is there can be now what you mean pathological CTG is fetal distress. No? So when you take about fetal distress, there are main things that you need to explore. One thing is called supine hypotension. Second is maternal hyperstimulation. Thirdly, these are the ones, and then mainly there are three uh, emergency conditions. One thing is cord prolapse. Secondly, also you have uh, placental abruption, and thirdly you have uterine rupture. Uterine rupture. Okay. So when you talk about fetal distress, it could be supine hypotension, where now you have the gravid uterus. No, and the gravid uterus, guys, it presses on the IVC of the mother, and then there can be reduced blood flow to the heart of the mother. There's reduced venous return, thereby causing maternal uh, hypotension, and by that there can be fetal. The fetus can have reduced blood supply because of the reduced blood pressure in the mother. Okay, and guys, that is one of the main causes of this fetal distress. Okay, so what we can now here they are asking what is the next step of management. So next step of management, you will put the patient in the left lateral position. When you put the patient in the left lateral position, the effect of gravity on the IVC will be reduced. Thereby, then we can see if the CTG is getting normalized. So while you do that, you still go ahead for planning for an emergency section. But the first step you do is you tilt the patient in this side and see if the CTG gets normal. Because if that's the case, you don't have to do anything. Unnecessarily, if the patient you have to, yeah, because it's a very simple thing to do, and It's a very common cause for fetal distress. So therefore, you place the patient in left lateral position, and then you see. And then if still not resolved, then you take the patient to theatre and do the emergency C-section. Prepare type 1. Type 1 emergency C-section means emergency C-section which has to be done in 15 minutes. There's something called type 2. Type 2 is when you do an emergency C-section within 30 minutes of time. So those are some time duration ones. So that's what type 2 and type 1 are. But here in this case, the important thing is you put the patient on left lateral position, thereby to see if there are the supine hypotension caused by the gravid uterus pressing on the inferior vena cava of the mother, causing reduced venous return into the heart of the mother, and thereby causing maternal hypotension, maternal low blood pressure, thereby causing reduced perfusion to the fetus, and thereby causing the fetal distress. Okay, so that is that. So remember that. Okay, so I think there are a lot of things which you learned in this uh, uh, SBA. Okay, so we learned about what are the stages, and okay, so I'm not going to repeat. So go over this. You should always think like this. You should always think what stage you are in. Then you need to see if the fetal distress, uh, if there is fetal distress or if there is delayed stage of labor, because those are the two indications for you to intervene. The CTG might be normal, but if there's delayed stage of labor, you need to still go ahead and manage it, because you can't wait till there are abnormalities in the fetal CTG, because sometimes CTG might not pick up pathological things as well. So that's why we have something called delayed stage of labor also. Okay? So if either one is there, you have to intervene. And by intervening, here I have mentioned the management. For first stage of management, these are the management ones. For second stage of management, these are the ones. One striking difference is this first stage of labor, there is no operational vaginal delivery. And why is that? I'm not going to go into detail, but if you read these things here, the easiest way for me to say is cervix is fully dilated. For you to reach pretty vaginal delivery, the first cervix has to be fully dilated. And when it's a cervix fully dilated, that's the start of the second stage of labor. Okay. All right. Okay. Right. So then I go to the next one. So this basically going to be this. Okay. All right. Next one. A 35-year-old premature is delivered by cesarean section. Prolonged second stage of labor. Abdominal uterus is highly high. Abdominal palpation, leave it to right side. Pre-op is 11.2. Next step of management. Now, okay, so uterus is slightly high in abdominal palpation, leave it to the right side. Pre-op HB 11.2. Next step of management. So then what's the best step we can do? So this is a case of secondary postpartum hemorrhage, meaning the postpartum hemorrhage occurring 24 hours after the labor. Okay. So in this case, what's the best thing you can do? Now, guys, I did not go into depth on why we do that, but there's a reason why we evacuate. Now, in this case, now, if you take this, all right. So now, when it took how to differentiate the causes of trauma or causes of postpartum hemorrhage, I said first thing is you look for retained products of placenta. You exclude that. You remove all of them. And still, if the umbilicus is up, then it's for sure atonic hemorrhage. So one reason why we need to go in this pathway is because, guys, now if you directly go for to see if the uterus is above, sometimes one thing is the uterus can be not contracted, that's why the uterus level is down. But also think if there were some products of retained products of placenta which is inside the uterus, that also can cause the uterus fundus to be above the umbilicus. Just suppose there are some things inside the uterus is still there. If that's the case, uterus still can be like that. And when you remove it, it can come down. So that's why we first take off all the retained products of placenta and then we see the level of the umbilicus. If it's still up, then you should for sure know that it's atonic hemorrhage. Okay. So that is the logic behind where you do retain protection placenta up and then go down. So now when it comes to this case, okay, when it comes to this question, uh, abdominal examination uterus is slightly high. So now uterus is slightly high actually can be because of one thing, mainly could be the fact that there could be blood in it. Okay, the uterus has not contracted properly and there is blood inside, or there could be retained products of placenta as well. So we don't know what it is. So when what we can do is uh, 11.2 is okay. So then what we can do is we can do a pelvic ultrasound scan and to see what is inside this uterus. Is it blood, or is it the fact that the uterus is not contracted properly, the uterus is big, or if there are retained products of placenta and things like that. Okay, so pelvic ultrasound scan is going to be our option. Okay, and depending on that, you can decide if you want to reopen the abdomen or not. Okay. Next one. A 38-year-old mother coming in 39 weeks of gestation. Uh, she has delivered 4 children before by uncomplicated vaginal delivery. This pregnancy is otherwise complicated, has single fetus with transfer slide. What is the best management of her? This is a classic question, and the answer is going to be admit for ECP. All right, so see if I have put it here. Okay. Second. So guys, this is a question about ECB, where we put some patient, change the position of the fetus. So here I have given some example, some information about what ECB is. Okay, and I've given success rate, and these factors that affect ECB success rate. Okay, it's important. Is asked relentlessly in your MCQs. Okay, so take a screenshot and keep it with you. Another list which you need to remember if you go for the exam. When to do ECB for nulliparous patient should be 36 POA till term, till labor, and multiparous 36, 37 weeks onwards till labor. We don't do ECB during labor. When the labor has onset, we don't do ECB. But other than that, there's no upper limit. Okay. All right. So this patient 39 weeks, no? So 31 weeks. It's a multiparous patient. So it should be done 37 weeks and beyond. So therefore, we can go for ECV. Okay. And you make the patient a vertex presentation, cephalic presentation, and we can deliver by normal vaginal delivery. Next one. A 26-year-old primary presented to the antenatal clinic at 34 weeks of gestation. Her symphysis frontal height is 30 centimeters. What is the most appropriate next step in the management? Now, guys, this is a classic symphysis frontal height less than dates pregnancy, because usually from 30 to 36 weeks, the period of amenorrhea has to be plus or minus the SFH. Period of amenorrhea, the difference between the period of amenorrhea and the SFH has to be 2. Now it is 34 weeks, no? 34 weeks of gestation. The symphysis of fundal height has to be 32 to 36. That range. Yes. No? Plus or minus. Okay. So 34 plus 2 is 36. 34 minus 2 is 30. 34 minus 2 is 32. So now this is a patient with a even lesser symphysis of fundal height, which is SFH is 30. Now when you have this sort of a patient, okay? When you have this sort of a patient, what is the next step? So basically, less of understate. The next step you do is, remember this, okay? The next step you do is you do an ultrasound scan for fetal biometry. Fetal biometry. Where you look at the most sensitive marker of most sensitive marker of growth, which is the abdominal circumference. You have the head circumference, you have the uh, the bipyramidal diameter, parietal diameter and all. But the most sensitive marker for fetal biometry, most sensitive marker or uh, most sensitive part of the fetal biometry to get affected by anything pathological happening is going to be our abdominal circumference. Okay. Okay. So then you do for that. And if that is abnormal, the most important uh, next step is going to be to do the umbilical artery Doppler. Umbilical artery Doppler. Okay. Umbilical artery Doppler. Okay. So those are that's a few steps. So in this case, this patient is having a what is the most appropriate next step in management? It's going to be ultrasound for fetal biometry. Okay. All right. Next one. 28 woman in her second pregnancy present to the antenatal clinic at 16 weeks. Her first pregnancy, she had a preterm labor at 28 weeks. Her transvaginal shows cervical length of 20 millimeters, which is the most appropriate next step of management. So now in this case, guys, if you can remember our cervical surcharge and progesterone, actually, this patient is indicated for both because the patient had a preterm labor and the transvaginal ultrasound scan shows a cervical length of 20 millimeters. Now, if you go and check for the indications of if you see for the indications of uh, so here, cervical length, indications of cervical surcharge, there's something called the ultrasound scan indicators cervical surcharge. That's the short cervix, less than 25 millimeter plus history of a preterm delivery. So therefore, in this case, both are fulfilled, no? Preterm labor and the short cervix of less than 25 millimeters. So it is 20 millimeters, so it's less. So therefore, cervical surcharge is indicated. Also, the patient is um, so if you take the indication for progesterone, you see the same thing. So this is or a history of preterm birth or history of T2 miscarriage or stillbirth or cervical length of 25 millimeters or less in the transvaginal scan. So in those cases also, so basically cervical surcharge and progesterone both are indicated in this patient. So what shall we do? Now, cervical surcharge you can do in the next available theory list, but they ask you what's the most appropriate next step of management. So then you can start the patient on oral or vaginal progesterone. Okay, and then go with cervical surcharge in the next theory list. But if they had asked what is the best management? Now, if you have been asked what is best out of vaginal progesterone or cervical sarclage, what is best? Then cervical sarclage is the answer. But in this case, if they're asking what's the appropriate next step of management, you can start the patient on vaginal or oral progesterone and then give the patient a date for a cervical sarclage in the next available theater list. Yeah. All right. Aspirin, no. Repeat cervical length again in 2 weeks. There's no point. Textile bacterial vaginosis. Now, remember a very important thing. I think I mentioned that in the previous question, one of the previous questions also. Bacterial vaginosis is known to cause under recurrent UTI, under recurrent miscarriages. Question, I told that bacterial vaginosis is one of the commonest cause for this recurrent miscarriages in infection. Therefore, it's also important that you exclude them. But in this case, the most appropriate thing is when you see there are indications, there are problems, you need to treat them. Okay. All right. Okay. So that and these two are both needed, but in my opinion, I should go for, because they ask the most appropriate next step of management, you can go for vaginal progesterone. But if had they asked the best management, it would be in the surplus, because surplus has a much more effectiveness than the vaginal progesterone. 36-year-old primary mother with an uncomplicated antenatal period admitted at 37 POA, ruptured membranes for 24 hours, speculum examination shows clear fluid, and cervix is 2 centimeters dilated. Other fetal and maternal parameters are normal. What is the best management? So now guys, what is this? This is the patient admitted at 37 weeks of POA. Therefore, the patient is in term where before the labor pains have come, before the labor has come, there's rupture of membrane. So this is called premature rupture of membrane, or what you call as pre-labor rupture of membranes. So what should you do usually? Uh, so, so when you have a patient with coming with PROM, okay, when you have a patient coming with PROM, we wait for 24 hours. And if labor has not started by 24 hours, then we have to go and induce the labor. We wait for 24 hours. That's PROM, we wait for 24 hours. So what is PROM again? PROM is pre-labor rupture of membranes. Premature rupture of membranes, or pre-labor rupture of membranes. This happens for a patient which is 37 and beyond. If the same patient came at 36 weeks, then it's called as pre-PROM. Preterm, pre-labor rupture of membranes. So then the pre-PROM management is completely different from PROM management. Okay, that is completely different. I'm not going to again go into detail in this question, Okay, so I'm going to talk about PROM management. For a patient who is coming similarly like this, 37 weeks, coming with ruptured membranes, suppose they came just after rupture of membranes, then you take the patient into hospital. You you confirm that there is PROM, there's rupture of membranes, by looking by the speculum examination, as the patient mentions. You see clear fluid in the posterior fornix, and then what you do is you wait for 24 hours. You expect the onset of labor, spontaneous onset of labor within 24 hours. And if that has not happened within 24 hours, then after 24 hours, at the point of 24 hours, we are going to decide to induce labor. So induced labor will depend on what? Your Bishop score. If the cervix is ripe, we can go for oxytocin. If the cervix is not ripened, meaning if the Bishop score is unfavorable, you can go for prostaglandin. We don't do folic acid induction in PROM because there's a risk of we introducing infection from outside into the uterine cavity when you put the folic acid in. Administering erythromycin is a practice which is done in pre-PROM to prevent the occurrence of chorioamnitis. Delivered by emergency C-section, not needed at this point. Folic acid induction is not done because of the risk of infection. Observe for more than for 48 hours, no. We observe for 24 hours. Then if there's no, then 24 hours, by 24 hours, if there's no spontaneous onset of labor, then we have to induce the labor. That you do by looking at the cervix stage, the Bishop score. If the cervix is ripened, then if the Bishop, that means if the Bishop is good. If the cervix is favorable, then you can go for oxytocin. But if it's not, you can go for prostaglandin to ripen the cervix. Therefore, option is going to be oxytocin infusion. Okay. All right. 34. 26-year-old pregnant lady presented with dysuria, increased frequency. Okay, so this patient is a patient who is having sort of features of low abdominal pain, low-grade fever, increased frequency, mainly a lower urinary tract infection. No? We need to treat the patient. So all of these drugs given here are things which is given for urinary tract infections. So out of these drugs, the drug which is not recommended to be given in the pregnancy is ciprofloxacin. Okay, Cipro is not recommended. quinolones are not recommended to be given in uh, pregnancy. So all the others can be given. I mean, nitrofurantoin also is not usually given during the very clear near in term. Near in term, you don't give nitrofurantoin also. Near in term, you don't give nitrofurantoin also, but I think it's 28 weeks, okay. But quinolones mainly uh, is a drug which is not given in pregnancy. Okay. And here I have given you a set of drugs. A set of drugs which have been shown to have good safety record. So on the antibiotics, cephalosporins here. So ceftriaxone is a cephalosporin, cefalexin is a cephalosporin, coamoxiclav is a penicillin, penicillin plus carbonic acid, and nitrofurantoin. So here you see all of these are okay. Yeah, these are all okay. And nitrofurantoin, as I mentioned, avoid near term. But then that's fine. So this is a good list of drugs which you can use during pregnancy and something. Just have a rough idea of what sort of drugs are there. Okay, don't have to go in and out and learn everything. Just have a rough idea. Antibiotics mainly and antiemetics. So something like you know antiemetics like metoclopramide is going to be problematic in patients who are uh, in pregnancy. Okay, so write that. Have a rough idea. Okay. Okay. 25-year-old para 2 in her third pregnancy came with per vaginal and constant abdominal pain at 34 weeks of POA. So per vaginal bleeding after 24 weeks. I think we mentioned about the fact that if there's bleeding from the vaginal tract or genital tract after 24 weeks and before term, that is what you call antepartum hemorrhage. So when you have antepartum hemorrhage, okay, so if I go back to that, this is the antepartum hemorrhage. So antepartum hemorrhage, mainly there are two main differences we should be worried of. One thing is placental abruption. The other one is placenta previa. The main way to differentiate these two is this is a painful, constant painful bleed. This is a painless bleed. Very important concerns. Okay. So this patient is basically having a placental abruption. The patient has proteinuria of 3 plus. So that's hypertension, proteinuria. What does that tell? That the patient is having a preeclampsia. That is one thing. So on top of preeclampsia, the patient also has what? Placental abruption. So no, the patient has uh, placental abruption. Okay. So okay. So preeclampsia is fine. No, there's 2 plus or more. No? So that's okay. Just change the hypertension plus proteinuria. That's preeclampsia plus there's placental abruption. On auscultation, baby's heart sounds were not heard. So unfortunately, there is intrauterine death also. Intrauterine death also. What is the management to be done? Now, in this case, guys, uh, uh, what is the management to be done? So, what's the best management? Okay, so there are many things which you need to do because now in this sort of patient, there's a high chance of DIC. So, you need to look for coagulopathy and correct them. CTG obviously is not needed here. IV cannula and blood transfusion you should do. Okay, but the most important thing for now, when you talk about preeclampsia, now, guys, remember this placental abruption, intrauterine demise, and everything is actually because of this preeclampsia. So if you ask what is the cure for preeclampsia, no, because this patient is having 160 blood pressure still high and no. Okay, so the patient is in risk. So the main problem with preeclampsia is the fact that the placenta. It's a problem in the placenta. Okay, no, nothing else. Okay, so if you go look and if you get at a hypertension in pregnancy notes, you will see why preeclampsia occurs, no? Because of these various uh, various uh, uh, substances which is secreted by the placenta, which causes vasoconstriction by shift, and that's how preeclampsia occurs. So therefore, the main idea is to get rid of the placenta. So therefore, the main one is you should go for emergency LSCS where you remove the placenta. Okay. All right. So here guys, you can take a screenshot and this is sort of the management of a placental abruption. Okay, placental abruption. So here in this case also if there was the cervix was fully dilated and everything, we could have gone for an instrumental vaginal delivery also. The cervical dilatation was there and everything, you can go for vaginal delivery. But now in this case, since this does not show anything related to the now in this case, obviously 34 weeks, no, there are features of labor or labor progression. So therefore, it's not favorable for labor. Therefore, we go for emergency LSCS. Okay. Mainly, what is the main reason? To relieve the patient of the take the placenta out. To take the placenta out because that's the one which is causing all of these problems. Okay. Next one, a 19-year-old primary mother presented with accidental and emergency with diastolic fits at POF 35. Her fits continue for 15. She does not have a cannula. Blood pressure is 170 by 110. She has generalized body swelling. What is the first time management? So this is a classic history of a patient coming with eclampsia. Eclampsia. Okay, what is eclampsia? Eclampsia is a patient who is having a fit or a seizure in the background of preeclampsia. So the magical drug, the drug which is used to both prevent and treat seizure, prevent and treat eclamptic fit. Eclamptic fits are magnesium sulfate. So you should know a bit about magnesium sulfate, on how to give magnesium sulfate and all. Everything you need to know about magnesium sulfate I have given in this case. Loading dose 4 grams diluted in 20 milliliters. Maintenance 1 gram per hour infusion for 24 hours. And continue for 24 hours following last fit or 24 hours postpartum, whichever is long. If there's giving IV, difficulty IV, you can go 5 grams deep IM into each bottle with 1 ml of 2% lignocaine in same syringe. And the maintenance also we have given right there. And this is a practical way of how to make this loading dose and the maintenance. Sometimes can be asked mainly in the OSCEs for MCQs. Okay, so now in this case, now this patient is what? The patient is fitting, no? So now the patient is fitting, there is no IV cannula, when you wait for things. No. What you're going to do is you're going to give the IM max sulfate 5 gram bolus. Okay. Sorry, this one. 5 gram deep IM into each buttock with that amount of lignocaine. Okay. So important thing. All right. And also, guys, now one can argue the blood pressure is also high. So shouldn't we control the blood pressure and then go and give the max heart rate? No. Okay, remember that. Whenever you have a blood pressure, and even if the patient came with now in this question, guys, the patient is having a chronic fit. No, there are fits. No, there is also something called impending eclampsia. There's something called impending eclampsia. What you mean by impending eclampsia is features in the patient who is having a preeclampsia who is just about to get an eclamptic fit. So what you mean by those is if the patient with preeclampsia comes with okay. Now suppose there's a patient who is coming to you with preeclampsia where there's gestational hypertension. Let's say there was some proteinuria and okay, even if the proteinuria is not there, the patient comes to gestational hypertension and they have this blurring of vision, flashing, these neurological things, severe headache, clonus, papilledema. If the patient comes with those, that is what you call a impending eclampsia. Impending eclampsia means eclamptic fit is just about to happen. So in those patients also, so in even those patients, the first line two is to prevent the eclampsia, prevent the eclamptic fit. Therefore, first line should be go for max sulfate, and then only you go for labetalol to control the blood pressure. So unless the blood pressure is like 220, about 200 and all, because if the blood pressure is more than 200, 210, 220, then uh, you will have to control the blood pressure because now the end organs in the mother also can get damage of that too. But a blood pressure of 170, 180, 160, 170, we will be worried. We need to manage that. But before that, we need to see if the patient needs max sulfate. Okay. Max sulfate will take a higher precedence, priority than the labetalol. Just have that in mind when you answer your question. Because sometimes people come asking, okay, if it is 160 by 110, and also the patient is coming to a severe headache and visual disturbances, what are we going to do? Then you go for IV max sulfate, IV or IM, and then we go for the labetalol. Okay. Guys, remember, sublingual nifedipine is never given in, it's not given for blood pressure management in a pregnant mother because sublingual nifedipine can cause rapid reduction of the blood pressure of the mother and thereby cause rapid reduction of the perfusion to the fetus and cause fetal complications. Okay. Therefore, sublingual nifedipine is never used in pregnancy. Okay. For to control blood pressure. Go to the next one. 40-year-old multipara presented 2 weeks after normal vaginal delivery with fever and reduced urine output. Examination, patient was pale, temperature was 38, lower abdomen was tender. What is the most appropriate management option? So in this case, guys, this patient might be having some sort of infection. No, there's some infection occurring. Maybe after delivery, there might be some retained products of conception and just undergone infected. So what is the most appropriate management option? Where you should start the patient on IV fluids, resuscitate the patient and all, but the most important thing is you need to take blood cultures. Okay, you need to take the blood cultures and start the broad spectrum antibiotics. Okay, and then you can arrange for immediate evacuation or retained products of conception. Okay, and before that you should do ultrasound scan and do that. But for initial stabilizations and all, most important thing is you take the blood culture for broad spectrum antibiotics and culture. You start the patient on IV fluids, that's true, but in this case, most important thing would be blood spectrum and culture. Uh, all right. Blood transfusion is not needed. IV fluids is needed. Okay, all right. 19-year-old primary mother. What is fit? I think it's it. Okay, I think there's a mistake. Second, IM max sulfate 5 IM goes. Okay, the next one. A 45-year-old lady presented with irregular heavy menstrual bleeding, postpartum bleeding, and smelly vaginal discharge. She never had cervical staining or spectral examination. There was an irregular mass originating from the 3 o'clock position of cervix. Punch biopsy has been taken. What information would you expect on the histology report? Okay, so in this case, guys, what usually a histology report would say is the grading. Okay, what a histology report usually will tell is the grading of a disease. Okay, so what you mean by grading of a disease is it will look at what sort of a histology is there. Okay, so now I will tell you some examples for that. Okay, so these are types of biopsy reports that you get in a cervical histology report. These are type of histological reports you get from cervical biopsy. Normal biopsy, CIN1, CIN2, CIN3 is carcinoma in situ. And then you have AIS, which is adenosarcoma in situ. And then you have invasive squamous cell carcinoma, invasive adenosine carcinoma. So these are the main types of reports. So here you can see it will give an idea of one thing is it will give an idea of if it is a squamous cell carcinoma or adenosine carcinoma, and it will tell if the basement membrane has been eroded or not. Basement membrane has been eroded or not. Okay, so that is that. So and then more importantly, they will also give rise to how if they will also give the biopsy report will also give idea of how much cell division is there and other features of a malignant cell. Okay, so those are the main things. So this is what we call grading. Grading. How much of differentiation is there and all. So usually when you take a biopsy report as a whole, okay, if you take a biopsy report as a whole, what the biopsy report will give you is a grading of the disease. Okay. Local infiltration and staging. So staging, what do you mean by staging of the disease is how much of spread is there. Now if you take a cancer, what's the main problem for cancer? Cancer is a growth of cells which has a which has the chance of spreading to other places in the body. So that spreading can be in the local area and in the distal area. So uh, local infiltration of the cancer and staging of the disease. So they basically the same thing. Staging of the disease, as I mentioned, can be a local infiltration, the local spread, and the distal spread. So when it comes to uh, when it comes to uh, the when it comes to when it comes to cervical cancer stage, okay, when it comes to cervical cancer staging, now this is very important, guys. This is very important. Cervical cancer staging is mainly clinical, as it is done by examination under anesthesia. You see, vaginal examination, they will see for the growth, size of the growth, involvement of the vagina. Rectal examination, they will see the involvement of the rectum. Okay. Combined rectovaginal examination, they will see for the involvement of the parametry. Imaging is also used. CT scans and everything is also used, but it is just used as an aiding for stage. Okay. It's used just as an aid. So I'm just telling from my MCQ point of view because my main priority is for to get to the MCQ. So this is a very common thing they ask. What is the main modality of cervical cancer staging? If they ask that, the answer is clinical. The answer is clinical. And when it comes to gynecological malignancies, it's a very common and commonly asked question. For uterine cancers, uterine cancer staging, it is going to be surgical pathological. Pathological. For ovarian cancer staging, it's going to be surgical. For cervical cancer staging, it's going to be clinical. Clinical staging with examination under anesthesia. This is a important thing. Remember that when you go for the exam. Okay, all right. Does it mean that imaging is not used for staging? Yes, it is used. Imaging is used for staging because by using vaginal examination, rectal examination, you can't see if there's spread to others part of the body. So you should go for uh, imaging as well. It's just used for aiding. clinically, but for clinical, but what primarily book says is cervical stage is staging, is clinical stage. Okay, all right. So that's that. And prognosis report. Prognosis of the patient. Prognosis of the patient again depends mainly on the staging. So we are talking about the cervical CA. No? The cervical CA, guys. The prognosis of a cervical cancer patient will depend mainly on the stage. Okay. Whereas, now this is also very important thing. If you take the prognosis of a patient with a uterine carcinoma, it will depend on a lot of factors, like the histology, the type of uh, uh, histology, if it is a endometrioid type, or if it's a serous cell carcinoma, or something like that. So it depends on a lot of things, uterine carcinomas. Okay, but when it comes to cervical CAs, it's mainly going to be depend on the stage, the histological type. Okay, if the uh, cervi is a cervical adenocarcinoma or squamous carcinoma, it's not going to be much uh, going to have an effect on the cervical, the prognosis of a patient with cervical carcinoma. But if it is a serous cell carcinoma, or if it is an endometrioid type carcinoma, because there are two different types of histologies you see in uterine carcinomas, depending on that, your prognosis is going to depend on that. So important aspects. Okay, let me show you a more comprehensive differentiation. Look at this. This is to with the cervical CA. Okay, it's depend on the stage and the lymph node status. Histological patterns, HPV type, and grading. So when you talk histological patterns, then you have the squamous cell carcinoma or adenosine carcinoma for cervical CA. Doesn't have to have prognostic implication, but this is for uterine carcinoma. The tumor type, grade, depth of myometric invasion. Yeah, also the lymph nodes and everything is there, but other than the lymph node stage, here also the stage is important. No, the depth of myometric invasion, this adenexe, all of things are talking about the stage, but not just the stage, but the grade and the tumor type. They are also important for the prognostication of the uterine carcinoma, but it does not mean a lot for cervical carcinoma. Okay. All right. Okay. So next one. One second. Uh, so this is a 34-year-old para 3 presented with early pregnancy clinic with abdominal pain and brownish discharge. She is on copper IUCD for 2 years. Her urine pregnancy test was positive. Observations were normal. Speculum examination shows that IUCD could not be found. OS is closed. USS reveals empty uterine cavity. Endometrial thickness is 6 millimeters. IUCD in the lower uterine cavity, no adnexal mass. What is the most appropriate management plan? So now, okay, now the thing is now this patient is a patient who's coming to with abdominal pain, 34-year-old. So even though the patient is on IUCD and all, what is the cardinal rule in gynecology? If you even don't know anything about gynecology, this is something you should know. Is the fact that any patient, the reproductive age, 15-49 years of female, coming to you, especially with things like abdominal pain, is having a ectopic pregnancy unless uh, proven otherwise. Okay? So there's no question about it. Now in this case, what you need to do is uh, we need to see if there's an HCG increase. Okay, because IUCD is a contraceptive, but if we spoke about it before at the start, I mentioned that having IUCD, if there is a pregnancy occurring, there's a higher chance of uh, ectopic pregnancy occurring. So that's a one red flag, the risk factor there. Abdominal pain is a risk factor. That's the symptom. And yeah, so we need to sort of see for a beta HCG levels. Okay, that's the main thing. That's what the question trying to say is regardless of the patient being contraceptions and all. Okay, sorry, my bad. Okay, sorry. They say her urine pregnancy test is positive. Okay, so urine test is positive. Sorry. So there is HCG. There is HCG. There HCG is there. So then okay, now we have a problem here. The HCG is actually there. So higher amount of HCG, but the ultrasound scans reveal empty uterine cavity. Okay. So this is something which you call as pregnancy of unknown location, guys. Okay. This is something called pregnancy of unknown location. When you have a positive urine HCG plus a negative scan. Negative scan, because if it is a if it is a if there's a positive HCG, you should be able to see a intrauterine pregnancy or an ectopic pregnancy on ultrasound scan. So if there's nothing there, it's a problem. So that is what you call the positive HCG and a negative ultrasound scan is what we call pregnancy of unknown location. There are three differentials. One thing, it's a very early intrauterine pregnancy. Intrauterine pregnancy. Or it could be a very early ectopic pregnancy, which cannot be still seen on the scan. Or it could be it could be a complete miscarriage. Okay. So how you are going to differentiate those two from these three is these three from each other is you are going to do serial beta HCG. Okay. So I'll show you the thing. So this is how you do it. Okay. So you do the urine HCG, and it will be usually positive when the serum HCG is more than 25. So in this patient, the serum HCG was positive. Sorry, the urine HCG was positive. And then you do the transvaginal ultrasound scan done. And usually if there was an ectopic pregnancy, you will see adnexal mass found moving separate to the ovary. And if there was an intrauterine pregnancy, you will see an intrauterine pregnancy inside the uterine cavity. Okay. Suppose there was nothing seen, which is the case which you see in this patient, no? Because the ultrasound scan revealed an empty uterine cavity and no adnexal mass. Okay, so now we are in this phase. Suppose nothing is seen. Then you do this serum beta HCG. Serial beta. So you do serum beta HCG and you repeat in 2 days. Okay. All right. You repeat it in 2 days. And then guys, so how you differentiate these three? So then if the rise is less than 63% and the fall is less than 50%, it's going to be very likely ectopic. See, I have seen here causes of pregnancy of unknown location can be identified by serial HCG monitoring. If it is an early pregnancy, if there's a proper uh, proper implantation in the intrauterine cavity, it's a proper pregnancy, So then the rise in the beta HCG will be 63% or more. This is proper. Okay. Ectopic, there can be a rise. There is usually rise, but the rise is not amounting to like an intrauterine pregnancy. This is early intrauterine pregnancy. Early intrauterine pregnancy. Okay, get it, no? Because a pregnancy should happen in the intrauterine cavity, no? So when the morula goes and implants in the uterine cavity, it puts the tropoblasts, the finger-like structures, which produces the HCG. So that same thing will happen even if the morula goes and implants in the fallopian tube, which is the ectopic pregnancy. But you can imagine the implantation process that happens in the fallopian tube is not as better like in the intrauterine cavity. So then that again in the fallopian tube also there will be trophoblast formed and there will be some sort of HCG formed, but it won't be amounting to like an early intrauterine pregnancy. Okay, so the rise will be not as 63% rise, and uh, uh, sometimes ectopic pregnancies. The now okay, so the next one is the other one is it's 50% or more drop in HCG. Okay. So we spoke about three things: of intrauterine pregnancy, ectopic pregnancy, and complete miscarriage. Complete miscarriage is a one where the fetus has gone out. The full fetus is gone, therefore the uterus is empty. But since HCG takes time to drop, it's still on the dropping phase. But uh, since the HCG levels is more than 25, any serum level more than 25, I said the urine HCG will be positive, no? So therefore, suppose there was a the fetus here and it had miscarriaged. The whole thing had come out, and when you do the ultrasound scan, nothing is inside. But HCG will take some time to come down. So by coming down, if we detect it at a higher level, you will see that the HCG levels, urine HCG will be positive, but the scans will be negative. But in the miscarriage, if you do the serial HCG levels, you will see the drop in the HCG will be 50% or more in 48 hours. So then what in middle? If so, early pregnancy, early intrauterine pregnancy has to be 63% or more thrice. Complete miscarriage has to be more than 50% drop in HCG. Whatever in the middle. Okay, suppose there is an increase in HCG level, but it's not amounting to 63%. Suppose there's an increase of 10% of HCG in 48 hours. Okay, it's an ectopic. Suppose there's a drop of 10%. Still, you should think of an ectopic and not a complete miscarriage. So if it is a complete miscarriage, it should be, the drop has to be more than 50% from the baseline. Okay. So that is what this whole thing says. If the rise is less than 63% and the fall is less than 50%, okay, you can put this as O. Or the fall is less than 50%, it's very likely going to be an ectopic. Where you do the ultrasound scan again, and if you can't see, then you have to go for laparoscopy. In this case, we have to do the serial beta HCG and see what is the case. If the rise is more than 63%, then you shouldn't be worried. It's a uterine intrauterine pregnancy. If the fall is more than 50% in 48 hours, then you should not be worried. It's a complete miscarriage. If it's in the middle, then you have to be careful and then you manage for an ectopic pregnancy. And how we do that is you do the ultrasound scan again, and if you still can't see it, you can go for laparoscopy. Okay. Next one, a 40-year-old lady with primary subfertility for 10 years, admitted to hospital for laparoscopy and dye test. Procedure new peritoneum was created with versus needle that is maintained through the procedure. Gas used to infiltrate in surgery was the gas. The gas which we used to use is carbon dioxide. Okay, carbon dioxide. But the reasons we use this, one thing is it's non-toxic. It does not create any embolism, no embolism. And it is a heavy gas than other gases. Right? Okay, that is that. So, okay, let's go to the next question. A 35-year-old teacher came with dysmenorrhea and dyspareunia for 1 year duration. She is also trying for baby for 2 years. Bilateral ovarian cyst measuring 16 to 7 centimeters and 4 into 5 centimeters. What is the most appropriate next step of management? This, guys, is a classic history of a endometriosis. This patient is having endometriosis. Why? There's dysmenorrhea, dyspareunia. Dysmenorrhea, dyspareunia. I think we spoke about this when I was talking about adenomyosis, and I said that adenomyosis is a type of endometriosis. Endometriosis mainly you have dysmenorrhea and dyspareunia, and also there is features of subfertility. and subfertility. And bilateral ovarian cysts are there 16 to 7 centimeters and 4 to 5 centimeters. So these are mainly could be moving now. It's usually endometriomas. Endometriomas. Okay. That is all true. This is very straightforward for endometriosis. But there's a problem. The problem is there's cysts, ovarian cysts. We need to exclude a malignancy. We need to exclude malignancy. Okay. After we exclude malignancy only, we are going to treat this as for endometriosis. Okay. Therefore, the main thing is we are going to do is CA125. Now again, CA125 can be an increase in endometriosis, but if we are thinking of the fact that these cysts can be if they have malignant potential, the CA125 will be very elevated. So therefore, do a CA125 and uh, do a CA125 and exclude the malignancy, and then go ahead with your management, which is going to be a laparoscopic cystectomy, like that. Okay, but some most appropriate management step is do a CA125 and exclude the malignancy. Okay, all right. 45-year-old lady with primary infertility for 3 years with severe dysmenorrhea and dyspareunia. In the ultrasound scan, there was no right-sided 18 to 4 centimeter endometrioma. Her husband's semen is normal. What is the next step in management? Now, again, if there are CA125 and anything, should always exclude the malignancy. Okay, because if there are cysts and all, you should exclude them. Then this is perfectly a patient who is having endometrioma. This is a patient who is having endometrioma. So when you have a patient with endometrioma, it straight away goes into grade 3 endometriosis. Grade 3 endometriosis. When you have grade 3 endometriosis, okay, so when you have endometrioma, the main management. When you have endometrioma, this is the management of endometrioma. Medical management is insufficient. We should go for surgical management. So the best thing is the cystectomy. Go for laparoscopic cystectomy. And remember, guys, there are four grades of endometriosis: grade 1, 2, 3, and 4. Okay. So when you talk about the grades of endometrioma, so as mentioned, there's grade 1, 2, 3, 4. So you have grade 1, 2, 3, and 4. So endometrioma comes under grade 3. Okay? Endometrioma comes under grade 3. Endometrioma and endometriosis is two different things. Endometriosis is uh, endometrial cells going outside to other places apart from the uterine cavity. Okay? Endometrial cells. You have the endometrial cells. No? You have the endometrial cells. These cells are supposed to be in the endometrial lining. If these cells migrate to other places in the body, that's what we call endometriosis. If the endometrial cells go into the myometrium, that is what we call adenomyosis. When the endometrial cells go into the ovaries, it's called endometrioma. Now, in this case, this patient is having endometrioma, which is grade 3. Now, for them, so laparoscopic cystectomy, you need. So laparoscopic cystectomy will treat severe dysmenorrhea and dyspareunia. And because mainly management of endometrioma, you have to go for cystectomy. Okay, but will the subfertility improve? Will the subfertility go away just because of the laparoscopic cystectomy? No, because you can see here grade 1 and 2 endometriosis, fertility is achievable following surgery. But grade 3 and 4, you have to go for other types of require other alternative like IVF, or you can even go for induction. So basically, guys, the proper answer for this is now laparoscopic cystectomy will treat the endometrioma, but it will not particularly treat the infertility. You have to go for ovulation induction as well. But since they are the next step, you should go for laparoscopic cystectomy, and then you can go for ovulation induction. If they had the best answer for this, if they did not have these things, would be laparoscopic cystectomy plus ovulation induction. Okay. Uh, Whereas had they just said severe dysmenorrhea and dyspareunia in the ultrasound scan, there were no endometriomas, but there was just only peritoneal flimsy adhesions. So in that case, just by doing surgery, you will get relieved of the severe dysmenorrhea, and you won't need to go for ovulation induction because it is a grade 2, grade 1. If there are flimsy adhesions, if there's some deep lesion in the pouch of ductless, then you can go for still you can go for fertility without having to undergo fertility treatment. Okay, just by doing the surgery, you can get the fertility back, and you don't have to go for ovulation induction. But for grade 3 and 4, once to treat that subfertility part, because when you have endometriosis, endometriosis, you have the dysmenorrhea, dyspareunia, those ones will be treated by the surgery we do. But the subfertility won't be for the subfertility to be treated, the fertility wishes to be fulfilled. If it is grade 3 and 4, you have to go for alternatives like ovulation induction and all. But if it is just grade 1 and 2 endometriosis, the surgery done to relieve the severe dyspareunia and all, they will in itself treat for the fertility as well. Okay. Okay, so next one, this is basically a 45-year-old mother of 3 presented with irregular heavy menstrual bleeding. Okay, can just read it. It's a long paragraph. Mainly, she doesn't have any significant medical or surgical history. And okay, so now when you talk about this question, it's basically irregular heavy menstrual bleeding, but no features of endometrial carcinoma to be shown or anything like that. And so basically, this is a patient who is having irregular heavy menstrual bleeding. Now, since it is irregular, okay, since it is irregular, okay, first thing, 45-year-old mother of 3 had, if this said the patient has completed their, if they had completed their family, no questions about it. 45 years old, you can go for TH and BSO. You can go for total abdominal hysterectomy and bilateral salpingectomy. But why can't we do that here? Because the patient, one thing is, they have not mentioned anything about the fertility wishes, and also the fact that if you do bilateral salpingectomy in this patient, they will undergo premature menopause. So therefore, TH BSO is out. Okay, that's all. Okay, so therefore, those because of the fact that they are not told that family is not complete, family is completed, and the other fact being premature menopause, we are going to not do D. Okay, so irregular. When you have irregular, meaning you have to have hormonal methods to correct it. Irregular means you have to go for hormonal methods. Therefore, tranexamic and mefenamic acid is out. The tranexamic and mefenamic acid you give only when you have regular periods, which is heavy, where you give tranexamic and mefenamic acid during the period of menstruation. So you have LNGIUS, COCP, and DMPA. Out of these 3 guys, now COCP is usually given for younger people, but for 45, more than 40 years of age, we are not a bit reluctant to give things like COCP because of the venous stem embolism risks and risks that associated with it. Otherwise, COCP is the best one to regulate the irregularity. Okay. Therefore, COCP, we don't recommend it in above 40 years of age female. Then you have LNGIUS and DMPA. So now here you know that LNGIUS is very potent. It's a very, very good way to treat these irregular heavy menstrual bleedings. Okay. For that matter, Even for a regular menstrual bleeding also, now suppose this patient declined surgery, okay? You want a long-term method to control the bleeding. Best is LNG-IUS, okay? LNG-IUS, always keep in mind, can be used for irregular menstrual bleeding, regular menstrual bleeding happening over a long period of time. And if the patient can't undergo surgery, in this case, there are no contraindications for surgery. But in this case, since they are not talking about any uh, fertility wishes and all, and also due to the fact that if you are going to go for bilateral salpingectomy, oophorectomy, there's going to be premature menopause, so then you don't want to have that. So you want to preserve the uterus, and also the best long-term strategy for that is going to be LNG-IUS. Okay, so always keep in mind LNG-IUS is a very good long-term strategy to prevent a heavy menstrual bleeding. Okay, regular or irregular. Okay, LNG use can be also used for regular ones, regular menstrual bleeding as well. All right. So important thing, LNG use. Okay. Next one. 32-year-old subfertile woman presented to gynecology with severe low abdominal pain. Um, uh, and there's pain during sexual intercourse. Periods are irregular. Uh, Uterus is retroverted, both ovaries behind the uterus. Both ovaries show 16 to 6 and 16 to 4 centimeters. Bimedullary exam shows POD. So all of these, basically, we talked about this. Now we talked about endometriosis again. No? Endometriosis again, and then endometriosis with cysts in the uh, ovaries. It's going to be endometrioma. Endometrioma. I think I mentioned what you mean by endometrioma. CA125 levels are 620, but elevation of CA125 levels is not just there for endometriosis. It can be seen in a lot of cases. These are the uh, examples. We don't need to know everything. Just need to know that it's not just cancers which causes increase in CA125 levels. There are benign causes like endometriosis, pelvic inflammatory disease, and all, which are fibroids, which causes increase in CA125 levels. So that's going to be that. Okay. Next one, you saw a 63-year-old woman with postmenopausal bleeding for 1 week duration in the gynecology clinic. Triple endometrial biopsy is performed. Okay. So basically, this patient is having something called this hyperplasia without atypia. Okay. So this management of hyperplasia without atypia, hyperplasia, management of patient with hyperplasia. It's a something which is been recurrently asked in the recent questions, recent papers. Therefore, know this. Management of an endometrial hyperplasia without atypia with atypia. It will without atypia, it will depend on the premenopausal or postmenopausal. If postmenopausal TH and VSO, premenopausal you can go for Mirena, which is LNG IUS. If it have with atypia, you can if there are fertility wishes, you can go for Mirena. If there are no fertility wishes, you can go for TH and VSO. Now in this case, guys, if the question stopped here, then we can directly go for this is a postmenopausal patient without atypia. Postmenopausal patient without atypia. So you can go for TH and BSO. But in this case, guys, now there's a problem. They say that there's a right ovarian cyst which is 16 to 7 centimeters. There's no increased vascularity around the cyst on the color Doppler. So on the Doppler, there are no features of malignancy or high risk features of the cyst. However, uh, you won't want to be careful, no? Because there's a risk that there's a chance that this ovarian cyst might be secreting some estrogen. Okay. Maybe something like um, something like a T-coma even, okay? Like a T-coma, okay? What you mean by a T-coma is which is seen in postmenopausal women, they produce estrogen. And this estrogen can go and act on the endometrium to cause hyperplasia. So, uh, a T-coma is a benign lesion. However, we want to exclude other malignancy that can be happening. Any estrogen producing management. So you would want to do a ovarian tumor marker test first. Do a CA125 level and exclude exclude any sort of malignancy. And then after that has been done, then you can directly go for discuss the hysterectomy and bilateral salpingo-oophorectomy. Okay. But here, first things first, you should always exclude the malignancy, probable malignancy. Okay. Or like a ECG circuiting thing. Mainly in a female, in a postmenopausal female, there's estrogen excess and all coming. It's mainly from something called a T coma. T coma. Okay. T coma. T coma is a benign sex cord tumor. Okay. Uh, because as far as yeah, okay, so maybe we'll come across this more ovarian tumors in the following papers to come. Okay. Okay. This one, for a 37-year-old woman presents with urinary incontinence, especially coughing when she's doing aerobic exercises. So following examination, what will be next step in management? So this is a patient coming with coughing and urinary incontinence. So that is what we call stress incontinence. So the main management for stress incontinence, or the main cause for stress incontinence, is weakness of the pelvic floor muscles. Therefore, the main treatment or the main management is going to be to increase the strength of these pelvic floor muscles. So how you do that is by doing the pelvic floor muscle exercises, where you do pelvic floor muscle contraction. So what you tell the patient to do is first teach the patient on how to do pelvic floor muscle contractions, and you ask the patient how to do. You ask the patient to demonstrate pelvic floor muscle contraction, how to do the technique, and then you assess it and you see if it is adequate or not. And depending on that, you assess it, and then you accordingly tell the patient, okay, do this more, and you tell the proper technique and tell the patient to do it continuously. That is how we are going to manage the stress incontinence, because by doing the pelvic floor muscle contraction exercises more and more, it will increase the strength of the pelvic floor muscles, thereby causing good muscular contraction, thereby improving the symptoms of stress incontinence. Categorization of urinary incontinence, request for 3-day voiding diary, they are mainly to do with urgent incontinence. Urge incontinence. Okay. Urge incontinence, where the patient is passing urine without even knowing. This, they are the ones where they have categorization of urinary incontinence, how it affects their day-to-day lives and all. Okay. And request for 3-day voiding diary, how much of it happens on a day-to-day basis. Referring to urodynamics is something else. And mid urine sample for microscopic culture and sensitivity, it's also when you suspect a UTI. Okay, so when you suspect UTIs, again, when there's continuous dribbling, or when they have urgent incontinence and things like that. For stress incontinence, when the coughs, there's urine passing, that's not to do with any urine tract infection. Okay, if there was an infection, they also will cause continuous urine discharge and not being able to control and no. So therefore, if the patient came with urge incontinence, then sending a midstream sample for culture sensitivity is acceptable, but not for stress incontinence. Okay, and also, guys, here I'm going to write some indications for urodynamics. Okay, this is also a list which you might need to remember before you go for the exam. Okay, one thing is urinary incontinence in a patient following surgery for prolapse. That's one indication. Okay, and if the patient is complaints of mixed urinary incontinence. What do you mean by mixed urinary incontinence is if the patient has both urge incontinence and stress incontinence. Thirdly, if there is failed medical management. Okay. So uh, for patient who is having surgery, just chest incontinence, urodynamics is not needed. Okay. But if the patient has chest incontinence, okay, urinary, okay, chest incontinence in the patient following surgery for prolapse, they undergone previous surgery for prolapse, and now they are complaining of incontinence, chest incontinence or urinary incontinence, then you have to do urodynamics, not before. Okay, before the surgery, for chest incontinence, you don't have to do urodynamics. Okay, yes. This is urinary incontinence in the patient following surgery for prolapse. Stress or urinary incontinence. Stress or urge urinary incontinence in the patient following surgical prolapse. That's the indication for urodynamics. Okay. All right. So those are the main things. So the answer is going to be A. Next one, 56-year-old woman had routine cervical cytology that was reported as high-grade squamous dyskeratosis. She was supposed to colposcopy and treatment of CIN. So she had undergone treatment for CIN3 lesion, usually a LLETZ at 6 months. She was found for low-grade squamous dyskeratosis. HPV was and it was negative. What would be the flag? So they are basically there's a patient who is having a low-grade squamous dyskeratosis at this point. No. So what you should do is then you should know this table as well. So we are talking about a patient who is having LSIA. So you have to what you do? You have to repeat the smear in 6 months. That's all. So depending on if SL and all. So but if they are higher grades one, you have to go for urgent colposcopy. But for low grade one and less IL, you can repeat in 6 months. This is HSIL. This is high grade squamous intraepithelial lesion. Alright. Next one. 50-year-old woman with a BMI of 30 kilograms per meter square presents with severe vasomotor symptoms. Uh, okay. Okay, all right. So this is basically a patient who is having severe vasomotor symptoms, no? And how will you manage vasomotor symptoms? So the main way to manage vasomotor symptoms is going to be using HRT. And the best one is combined estrogen progesterone HRT for 5 years. Okay, now here I have given you duration of HT. Depends on the indication. There are two indications for hormone replacement therapy. One thing is premature menopause. The other one is there are symptoms. Okay. Symptoms, you have hot flushes and all of these things. And you should know the contraindications for hormonal therapy also. Estrogen dependent cancer and high risk of thrombosis, high risk of cardiovascular diseases. Those are the very few contraindications for hormone replacement therapy. And then you should know there are various types of hormone replacement therapy. Each is an only one, E and P, which is combined. There's a sequential one, E and P, which is combined, and the uh, one. So then, second, this is the continuous one. So you have the sequential one and you have the continuous bridge. Okay. Both of these E and P, what you mean by is combined HRT. Combined HRT. So there are two types, the sequential one and the continuous one. Tibolone, long cycle E plus P, estrogen with LNGI-US and some local estrogen along. Okay. So out of this, the main one, the best one is this. The best hormone replacement therapy is E plus P continuous regimen combined. Combined HRT is the best out of all. And out of the regimens, the continuous one is better than the sequential one. Okay. And there are other non-hormonal treatments for menopausal symptoms like SSRIs, clonidine, all of these. Okay, and for management of low libido is where you have tibolo, and there are testosterone gel patches and all of things like that. And this is also very uh, this is a very well asked question, very popular question. So this combined hormonal therapy increases the risk of breast cancer, reduces the risk of ovarian, endometrial, and bowel cancer. Estrogen only therapy reduces the risk of breast cancer, increases the risk of endometrial cancer. So have this written down somewhere before you go for the exam. Remember this, put it in the exam, come back, don't go to question of why this happens in one. Okay? Well, remember it in way, write it down in the way, it's easy for you to remember. It's all MCQ things that they ask. Very bizarre, but can't help. Uh, Okay, so those are the main things we want. The last one. 48-year-old woman underwent vaginal hysterectomy and discharged on post-operative day 4. She was pale but hemodynamically stable. HB is 8.5 on speculation. There is active bleeding from vaginal vault, which is the most appropriate initial step in the management. So what you're going to do is you would want to examine under anesthesia and do some vaginal packing, and then close the keep it like that. So uh so example answer is going to be what? You put pressure, and when you can see that there's a problem in the vaginal vault, okay, you when put some gauze and just keep it bleed, and then examine well to see for the injury. Okay, all right. So that's about it for this question paper. Might have taken a bit long, but I think I covered extensively. I went a bit deep into I was able to talk around the subject as well, and hope extra knowledge also which you gain from this will be helpful for you to face the upcoming question papers as well. All right. So as always, if you have any problem, just let me know. And thank you very much for joining this session. Thank you.